For people who haven't attended, the Lugano meeting is now an every other year meeting. It is truly a global meeting. At this year's meeting, there were almost 4,000 participants with 90 countries represented. And just to give you a sense, there were over 400 people who attended that meeting from the United States. It's in a beautiful location in southern Switzerland, the Italian part of Switzerland. If I had to summarize key themes of this meeting, it would be that there's a wealth of riches right now for lymphoma treatment options. And given that, I think there was attention being paid to refinement of these novel therapies, a lot of preliminary data on novel combinations, an appreciation for toxicity and late effects. And I think some of these findings will result in future randomized trials. What I tried to select for this meeting were studies that could impact practice. And I believe there were at least 3 or 4 items that were discussed at the meeting that should impact practice, and we'll go through those. I'm going to start with follicular lymphoma, and I know there's a session this afternoon on follicular lymphoma, so some of this will introduce that session. The meeting begins with a closed workshop of about 50 or so investigators, again, a global group. And this year's topic was follicular lymphoma. The next speaker coordinated this workshop. And this workshop started with a deep dive into the known biology of follicular lymphoma, and a whole section on the microenvironment of follicular lymphoma, as well as a focus on the common progenitor cell of follicular lymphoma that could lead either to the phenotype of follicular lymphoma or of transformation. And I think what came out of this workshop was a discussion on the fact that most patients with follicular lymphoma are now doing very well. So this manuscript was discussed at the meeting that was recently published in JCO that suggested that if you treat patients with R-CHOP treatment, about 20% of those patients will progress within 2 years of that treatment, and that group of patients has a median overall survival of only 5 years. But for the other 80% of patients, they really have outstanding overall survival. And the suggestion is if we're trying to develop studies in follicular lymphoma, these two groups of patients really should be treated differently. The challenge is that we can't identify the patients yet on the green curve at diagnosis. So there was discussion, and I think a consensus was reached that this high-risk follicular lymphoma represents the key unmet clinical need in follicular lymphoma. And we have to figure out how best to identify these patients up front. So the M7 FLIPI score, which was published just about a month ago in Lancet Oncology, may represent a starting place for this effort. And you can see that there are several genes as well as clinical prognostic factors that go into this score. And the concept is that this score takes the high-risk FLIPI group, the clinically defined high-risk FLIPI group, and refines it to contain really the worst actors. And whether this score becomes the score to identify the high-risk patients that were on that green curve I showed you, I'm not sure, but it's a starting point, and I think there's a lot of energy in the follicular lymphoma community now to try to differentiate at diagnosis patients who need more aggressive treatment versus the other group of patients who, in my opinion, are probably largely being overtreated right now. Really helping to emphasize this fact was the results of this FLASH project. This was a project that looked at a number of randomized trials in follicular lymphoma over the past 15 years, and we're really trying to look for an early endpoint rather than just looking at progression-free survival, recognizing that when you treat patients with follicular lymphoma with chemoimmunotherapy, median progression-free survivals now might exceed 5 years. And what they showed was that the CR at 30 months was a good surrogate for subsequent PFS. And they were making the case based on these randomized trials and this very large database that CR30 may be considered an appropriate primary endpoint in future first-line follicular lymphoma studies. So we'll move to Hodgkin lymphoma, where I believe there was practice-changing work, and that was this RATHL trial that was presented. This was a trial for advanced stage Hodgkin lymphoma, as well as stage 2 unfavorable. And basically, this trial was a response-adapted trial where patients received 2 cycles of ABVD and then got a PET scan. If the PET were positive, they were escalated to BEACOPP-type therapy. And if the PET were negative, they were randomized to either continue ABVD or de-escalate and take the bleomycin out. And no radiation was really planned for this group of patients. So the preliminary results are shown here. If you just look at the entire group of patients, the 3-year progression-free survival was 82.5%, and the 3-year overall survival was 95%. 84% of the patients had a negative PET scan after 2 cycles of ABVD. And in that group, remember, they were then randomized to either continue ABVD or have the bleomycin removed, and those 2 arms did exactly the same. There were only 14 deaths on each arm. In the 16% of patients who were PET positive after ABVD, their progression-free survival was 70%. So my thoughts on this study was that I think this does really emphasize that there is safety to eliminate bleomycin for PET-negative patients after 2 cycles of ABVD. Now, the definition of PET negativity is a formalized definition that has been published in JCO. It's not good enough to have a nuclear medicine physician just say the PET scan looks better. But if you adhere to the criteria, I think you can safely eliminate bleomycin. I think the other point to make is that escalation to BEACOPP for PET-positive patients appears to have a favorable outcome. That wasn't randomized, and in SWOG, we have presented similar data, which actually showed very similar results. But I think the other message here, and this is a plea to the clinical trialists in the room, is that PET scans are really not the total answer in Hodgkin lymphoma. 15% of patients who are PET negative after 2 cycles of ABVD still have subsequent PFS events. And in fact, the majority of the PFS events in these trials are happening in the PET negative patients, not the PET positive patients, because the vast majority of patients are PET negative. So I think right now PET is the best we have, but we have to come up with better surrogates that are likely going to be biologically driven. The other Hodgkin study that was presented was this one. This is a trial that occurred in early stage Hodgkin lymphoma that again had a similar type of design where patients got 2 cycles of ABVD and then had a PET scan, and if the PET were negative, they went on to additional ABVD. If the PET were positive, they escalated to BEACOPP escalated plus involved node radiation therapy. And this just shows that in the PET positive group, if you escalated, you did better than if you just continued ABVD. Both groups getting radiation therapy, suggesting that in the few patients who are PET positive after 2 cycles of ABVD with early stage disease, that escalation may be a good idea. I think that in this early stage population, we do have to wait, though. There's long-term toxicity that could be an issue when you combine BEACOPP escalated with radiation therapy, particularly given the favorability in the ABVD arm. The last thing I'll say in Hodgkin lymphoma was there was just an interesting abstract in the biology side in nodular lymphocyte predominant Hodgkin lymphoma. This is a very uncommon entity, less than 10% of Hodgkin lymphoma. And it's probably not really Hodgkin lymphoma, it's an indolent B-cell lymphoma. Histologically, it's been, has a very characteristic appearance with these popcorn-type cells. And this group suggested that an infection with Moraxella catarrhalis may be involved in the pathogenesis of this disease. And there are a number of examples of how infection can lead to lymphomas, certainly in the marginal zone and other non-Hodgkin lymphomas. The aim of this trial was taking the hypothesis that there's chronic antigen stimulation which leads to these lymphomas to try to identify the target antigens of these B-cell receptors. And they demonstrated several IgD positive cases that reacted to Moraxella infection. This is an early study, but it's interesting, and certainly we've had some lymphomas in the non-Hodgkin lymphoma setting that ultimately we treat with antibiotics. So I just thought I'd share that. Moving on to diffuse large B-cell lymphoma, I think another potentially practice-changing trial involved CNS lymphoma. This was a randomized trial that treated CNS lymphoma with either methotrexate, cytarabine, and rituximab, or a triplet combination that included methotrexate, cytarabine, and thiotepa along with rituximab. And then they subsequently randomized patients to radiation versus auto transplant. Only the first part of the trial was presented, and you can see that the CR rate and 2-year overall survival seemed best in this randomized trial when the thiotepa was added. Here are the curves, and you can see that this matrix regimen, which is the triplet regimen, behaved better than the other two regimens. Still, many of the patients, of course, are relapsing. This is not a panacea for this disease, but these patients seem to be doing better. Now, there's some problems that were brought up in the discussion when this was presented. This was a high-risk group of patients, but the outcomes were inferior to previous experiences. That methotrexate cytarabine arm, which was essentially the control arm, did worse than when it was studied by itself in a previous trial. So one always has to be concerned when the control arm underperforms. And I think that the question is, how does this compare with other induction regimens that are out there that might involve drugs like temozolomide or strategies of very high-dose methotrexate? And we don't know. But clearly, this is a large randomized trial that if you're comfortable using a methotrexate cytarabine backbone, I think including thiotepa is a reasonable thing to consider. We had an update on CAR T-cell therapy. I know you heard about this a little bit earlier at the meeting, but this was the Pennsylvania group that presented 19 patients with diffuse large B-cell lymphoma, including about a third who'd had a prior auto transplant. Very early days, but 5 of the 12 patients who were able to get the treatment, so already there's a big fall off, had a CR with 1 additional PR. The 6-month progression-free survival was only 37%. More interesting, here's the progression-free survival curve. But I was going to say more interesting is that in follicular lymphoma, they presented their very beginning data. Again, this is with a very short follow-up, just showing that almost every patient has had a response. So I think we're going to look forward to it, and maybe this could be a tool to use for that high-risk follicular lymphoma group once we're able to figure out exactly who they are. There are issues with this treatment as well. Is it ever going to really be exportable? I know there are trials that are going on now to try to demonstrate that. Perhaps the use of this is best in minimal residual disease states, like after transplant. And this is being studied in many institutions, including many that are represented here. The other thing in diffuse large B-cell lymphoma, there was a whole morning on new drugs. And I picked one that I just thought was interesting because they demonstrated activity both in vitro and in vivo in double-hit diffuse large B-cell lymphoma. This is this drug called selinexor. which is a selective inhibitor of nuclear export. It has a novel mechanism of action. At some level, it's a type of chemotherapy drug, but the fact that they showed a single-agent activity in a limited number of patients with double-hit diffuse large B-cell lymphoma, perhaps the worst acting diffuse large B-cell lymphoma, particularly in the relapse setting, I thought was interesting. And combination strategies would clearly potentially make sense. So we'll just conclude with some of the prognostic indices that were reviewed at this meeting. The first is a group came up with the CLL-IPI. The issue in CLL is that there are a number of different ways that you can have a conversation with a patient about their prognosis. And my experience when I see patients with CLL is lots of patients have some favorable and some unfavorable, and it's really hard to know what trumps what. They might have unmutated, but they might have a favorable cytogenetic profile, and which is more important. So this group tried to take a look at various factors, including 17p, which you heard about in the previous talk, the immunoglobulin mutation status, beta-2 microglobulin, and then stage and age. And they put a grade to each of these, recognizing that deletion of 17 is bad no matter what else is going on, but then these other ones have these different weights. And therefore, you could come up with a prognostic score, and looking at that score, you could come up with a risk group that looks something like this. And what they showed was that in both the training and a validation data set, that you could nicely define different risk groups of patients with perhaps some more refinement than cytogenetics. Now, I think a major limitation of this is that it's prognostic, it's not predictive, and it doesn't really tell us how to treat the patients on that red curve. But if you're having a discussion in clinic, this is something you could use. I think the other problem with this is we don't know if this is going to hold up in the ibrutinib or idelalisib era. We just saw curves that look very different, and in that case, it could be of historic interest. In mantle cell lymphoma, though, I think this is potentially going to be quite relevant. This was a presentation from the German group, and a manuscript is likely going to be coming out soon on this. This included 700 or so patients with mantle cell lymphoma from their group. What they tried to do was refine the MIPI score by adding the Ki-67 index. And what they showed were that the progression-free survival and overall survival, if you add this 30% cutoff for the Ki-67, range from 67% to 16% on progression-free survival and 85% to 17% on overall survival. And I think that clearly in that overall survival, you're getting a picture of the heterogeneity of mantle cell lymphoma. If you have a group of patients that have an 85% overall survival at 5 years, you're going to approach them very differently from a group of patients who have a 17% overall survival. Unfortunately, right now in clinical practice, many people are not approaching these patients differently. So I think we do need scores like this that people are going to use and help us interpret clinical trials. I think one other point that came out at the meeting that I just want to briefly emphasize, and I'm doing a little bit of the work of my pathology colleague who's going to follow my talk. The WHO is going to be updated again. In lymphoma, we never let more than a few years go by before we do that. We expect a publication in the summer of next year. Some of the new things that are likely to be in that new WHO classification were mentioned at the meeting, including in diffuse large B-cell lymphoma in particular, an expectation that cell of origin is determined in all cases using either immunohistochemistry or possibly newer platforms moving forward, and taking double hit lymphoma and putting it in its own category. Double hit being MYC positivity with either BCL2 or BCL6 positivity measured by FISH. My take-home messages, one, I think if what did I change in my practice after the meeting? I had a very low threshold to eliminate bleomycin for PET negative advanced stage Hodgkin lymphoma, and in fact, our group is doing that routinely now. I think one can consider using this matrix regimen with thiotepa added to methotrexate and cytarabine for primary CNS lymphoma. I think response-adapted treatment by escalating to BEACOPP in both early and advanced stage Hodgkin lymphoma who are PET positive after 2 cycles of ABVD. And honestly, for those of you in practice, I think you have to now start having a conversation with your pathologists to get ready for this WHO update and really start demanding that there's a routine cell of origin determination on all patients with diffuse large B-cell lymphoma, as well as routine FISH for MYC and BCL2. And our colleagues in leukemia would never treat a patient with acute myelogenous leukemia without knowing if there was the possibility of a 1517 translocation. So hospitals all over this country have adapted the ability to do those tests in real time. We're going to need to demand that for lymphoma care moving forward. I want to just acknowledge that we have great hosts in Lugano, and Dr. Cavalli and Dr. Giulmini have just done a fantastic job with that meeting. And if you ever have the opportunity to attend, I encourage you to do so, because it is total immersion in lymphoma from about 7 a.m. to 8 or 9 p.m. for 4 straight days. Thanks very much.